Hi, Lulu.
Hi, Anita. How are you?
Good. How are you? Good to see you.
Yeah, great seeing you again.
Thank you so much for doing this.
Yeah, of course.
So we'll just give it a couple minutes for people to join in, and then we'll get started.
Okay.
Hi everyone, and hi Lulu. Good to see you.
Hey, Ron. How are you?
Good, thank you. How are you?
I'm doing well. Good to be back for an hour.
Yes,
Yeah,
that's right.
good to have you back.
I see one of our fellows here. I'm just texting them. One other minute, Lulu. Right. Just I know we have at least one fellow on vacation, but others should be joining shortly. And Roma's here. So hi, Roma. So I'll just wait for the rest.
Hi.
Right, here we go. Great. Okay, well, we can go ahead and get started. I'd like to welcome back Dr. Lulu Go to present our sleep medicine grand rounds for us today. Dr. Go is she's both a Spartan and a Wolverine. She did her undergrad at Michigan State University along with her medical school there. She did her family medicine training and at the Hennepin Healthcare Family Medicine Program in Minneapolis, Minnesota. We were lucky to have her do her sleep medicine fellowship training with us, graduated a few years ago. And since that time, she's been working in different private practice settings in Arizona and now in the Seattle area at Kaiser. So she's going to teach us today about her her experience working in these different practice settings, different parts of the country. So super excited to learn from you, Lulu, and welcome back.
Well, thank you so much for that wonderful introduction. It is wonderful to be back and see some familiar faces and photos. When Anita asked me if I was open to maybe doing a presentation for Grand Rounds, I was like, heck yes. I've had really fond memories during my training here. So in any way I can give back, I'm very happy to do so. So let me try and share my screen. Okay, you guys see? All right,
Yeah,
can
we can see that.
Okay. Okay, perfect. All right, so the title to my presentation is called Beyond Fellowship, Navigating Career Paths in Sleep Medicine. And in reviewing my slides, I think I should have named this really Early Career, Navigating Career Paths in Sleep Medicine. I actually was just a recent graduate in 2021, about 3 years ago. So a lot of my perspectives as well as experiences is very much early career and will differ from someone who is more mid-career or later in their career. Sleep medicine is a rapidly developing specialty, and experiences in job searching or opportunities may present very differently 20, 15, 10, even 5 years ago than what it is today. So I would love, for participation. So this is very casual. If you have any comments or questions, feel free to chime in at any point during the presentation. I'll probably spend just over 30 minutes kind of going over the slides, but the point to this presentation really is to spark conversation and questions, especially for the fellows, the graduating fellows. I think this would be more applicable, but certainly I love hearing experiences from someone more mid and late career as well. So without further ado, I have no disclosures. So just an overview of my presentation today. I'll briefly touch upon sleep medicine as a specialty. This is something we're probably all very familiar about, but I do think it's important to kind of just touch briefly upon to kind of set the stage. I'll talk about my personal experiences in different practice settings, also touch upon alternative career paths and practice settings that, I've personally not, gone through, but I would love to hear other people's perspectives as well. And then lastly, I'll summarize with some pearls I've learned along the way. So Anita did a great job kind of introducing me. This is just kind of a quick about me. I feel like it is important to kind of just know my history, my training, my background in primary care, because that does dictate career paths in sleep medicine. When I was after graduating family medicine, I did work for a year in urgent care and ER. Found it a great year for learning, but didn't find it as professionally fulfilling as I'd like, and that's why I pursued sleep medicine. And from there, I went to private practice, and now most recently, this past year, I started at Kaiser as a sleep physician. And just the past 3 months, I was recently transitioned to the medical director of sleep medicine for the organization in Washington. So as we all know, sleep medicine is a very unique specialty. It recruits, candidates from no less than 7 medical specialties. And this is really what makes sleep medicine very unique, I think, as well as setting the stage for career paths down the road. It is a 1-year fellowship, 12 months, and it's required nowadays for sleep board eligibility or certification. In the past, that wasn't the case. And, a lot of people were grandfathered into sleep medicine. But nowadays, every job that you see requires, this fellowship or being sleep boarded or certified. So the growth of sleep medicine, hashtag choose sleep. You may see that a lot on the AESM website. So it's definitely a growing specialty. When I was in fellowship back in 2020, 2021, I think there were just over 80 or close to 90 fellowship programs. But when I checked recently on the AESM website, this has grown to 100 sleep medicine fellowships. This is an attempt to address really the dire lack of sleep specialists needed in the future to address the disease burden. The practice of sleep medicine likely will, change significantly in the next few years. The increase in consumer wearable technology. I mean, every month there's like new technology, new updates to systems. It's hard to keep up, but likely, we do have to embrace this. And, I think for the better, it will change how we practice. Telehealth, sleep medicine has really solidified itself in the past few years, especially during COVID, as a great specialty for telehealth. And this is great because I think there are a lot of people in certain areas that aren't able to see a sleep doctor face to face, and we're able to, address most of these needs via telehealth. And then lastly, AI. We've heard of this term probably so much in the past year. AI, it's taking over, it's going to change medicine. And it's likely true, that, I'm not an expert on. I think Dr. Kathy Goldstein probably is the professional on AI, but certainly that's something to consider, maybe of how we deliver care, or, feedback for patients, for PAPware, all these things that, I think AI can play a role in the practice of sleep medicine in the future. One thing to note with sleep medicine, as with many medical specialties these days, when you kind of decide your practice setting, is that there is a decreased reimbursement per Medicare, unfortunately, even though there's a growing need. It doesn't really reflect this in the decreasing Medicare reimbursement. I think just this past year, Medicare made further cuts. So it's disheartening, especially with, rising, with inflation and cost of labor. But about 10, 15 years ago, I think there was a significant cut already for in-lab sleep studies performed outside of a hospital setting. And as a result, a lot of private practice sleep labs had to close. But this is also, an example here of, a home study reimbursement per AESM data, right? Back in 2019, this was about $370, and in 2022, this decreased to $87. So a significant decrease, and something really to consider when you decide on, practice settings, as well as if the practice is sustainable long-term. So this is, take you back to class of 2021. This is my class, and we're a pretty good looking group, if I do say so myself. So out of the 7 of us, to give you an idea of what we pursued, so 2 went into, we're neurology boarded. So 2 of us went into academic sleep medicine with neurology. With a neurology mix, but predominantly sleep medicine. 1 was boarded in pediatrics, and she ended up going into pediatrics with some sleep medicine. 2 of us, including me, went into private practice with 100% sleep medicine, with one of us then pursuing a Palm Crit fellowship after the 1 year of private practice. And then one of us directly went into a Palm fellowship, and he'll actually be graduating this year, starting at a practice of a mix of Palm as well as sleep. And then lastly, one of us actually went back to our primary specialty in internal medicine after graduation. Okay. So back in end of 2020, 2021, I was taking my first steps. So the first thing really is kind of assessing what my needs were, what I wanted. Geographically, I was limited to the greater Phoenix area. My husband was finishing up his fellowship in the area, and he still had 2 more years. So we didn't want to be long distance anymore. I wanted to do 100% sleep medicine. One thing to consider when you kind of embark on your journey in your first job search is really, what is your primary specialty? I would say that there are a lot more opportunities available for someone who is boarded in neurology and pulmonology, especially pulmonology. as a lot of these clinics, historically started from these, sleep medicine historically kind of started tied to these two specialties. And a lot of clinics would want you to practice, say pulmonology, help with the call schedule, but also see sleep medicine patients. And that obviously is something I'm not able to do. So I was limited in terms of certain clinics that were open to hiring someone with a primary care background. And then you kind of have to decide, well, do I want to go into private practice, a hospital setting versus academic versus just something else, maybe going back to my primary specialty. Ultimately, I decided in private practice. Every metropolitan area, you'll find that they kind of practice sleep medicine a bit differently. In the Phoenix area, there was, I would say, less of a academic presence in the area for sleep medicine. A lot of the private practices were seeing very complex patients as a result. Most of the opportunities available definitely were more private. So as a result, I applied to 3 different positions and ultimately decided on a private practice called Valley Sleep Center. It's the practice I worked at was located in Scottsdale, Arizona. And the practice, Valley Sleep Center, it's basically AASM accredited, which I think is very important. It had 8 clinics with its Tide Sleep Labs. And it was mostly all located in the Phoenix area. It's by far the biggest sleep organization in the area. Curiously, it was actually established in 2002 and currently owned by a respiratory therapist. She saw the need back in 2002 in the community, the growing Phoenix area, and this kind of flourished into a very successful practice. Now there's some, I would say, pros and cons with a sleep practice owned by someone that I would say is a non-physician, but she made it work. She was very receptive to physicians' input in terms of practice standards. But also she was very business savvy, which is very important in the private practice world. We did full spectrum sleep care management, with all the labs doing Inspire titration. So really the full spectrum of sleep medicine. Also had a full-time CBTI sleep psychologist, and those are rare and hard to come by. So that is very important, I think, in choosing a practice. Ultimately, private practice is eat what you kill, right? So whether it's RVU based, it's really dependent on how many patients you see and what procedures you do. Now, something very important to note, I think, with private practice is that most of these private practices actually operates its own DME company. Now, you may ask, like, how does that work with the Stark Law? But we're not able to refer Medicare patients to these DME companies that the company owns, but you can certainly refer commercial paying patients into these DME companies. And it may sound, not, when I first kind of got into this world, I was like, I don't know, like why, well, Apria is not much better, right? But it's still, you feel like, is this, allowed? Is this right? Is this ethical? Funneling these patients into the DME company. But it's unfortunately needed these days, especially with decreased reimbursement. I would say most private practices, get 80% of their revenue actually from DME companies rather than patient care, unfortunately. Most sleep labs these days, they're breaking even, if not they're losing money, just with very high overhead costs. So in order to kind of stay afloat, most of these practices will have their DME companies that they funnel patients to. So other private practices I've interviewed at or encountered, a lot of these are physician owned, which is great. Many times, it's owned by either a palm critical care physician or a neurologist. There are some clinics that are non-physician owned, such as the one I worked at, Valley Sleep Center, it was owned by a respiratory therapist. I also interviewed at a position in Chicago that was dentistry owned. So how that worked is that they were looking to hire a board certified sleep doctor to read their studies and then basically, refer them to get MAD devices within the dentist within their clinic. So that was interesting, but ultimately I decided that probably wasn't for me. Um, Now, a lot of these practices, both hospital-based as well as private practices these days, are owned by private equity, unfortunately, but that's just kind of the scene, that's kind of the landscape right now. I think I read a recent article that said more than 30% of, healthcare practices these days are owned by private equity, and it's a growing number. And basically what that is just, it's a group of investors that purchase a practice or a hospital system, and they kind of, change things from top down, whether it's practice, the number of patients you see, different admin roles, they kind of change that as well to maximize profit. Ultimately, bottom line is they try to maximize profit. And then there are also telehealth companies that you can consider working for, and this is purely telehealth private practices. Some are owned by physicians, some are owned by these private equity companies or large hospital systems, and you could either just purely do sleep medicine and work full time for them, or they're looking for a doctor that's more per diem patients here and there whenever there's a referral. So in my experience, some of the pros and cons I've experienced in private practice, I think certainly a pro is you do get a bit more autonomy, I would say. There's, I put an asterisk there because I think autonomy, but you're still limited by the finances of the organization. So, your practice ultimately, it comes down to, is this profitable? So sometimes, it's limited, right? But I would say private practice, it is a wild west. You get to kind of carve out your own niche. You get to experiment a bit. I think for a new, graduate, I think that can be, pretty, I think it's fun, right? I think it's fun kind of exploring your practice. So I did appreciate that, coming out of fellowship. There was a lot more flexibility in the schedule. If I wanted to take, a few days off in like next week, I could do that easily. Especially since in a larger practice, my colleagues would fill in for me. Whereas, now I work for Kaiser, we have to book our vacations 6-7 months in advance. I would say private practice, compensation wise, I would say probably 10 to 20%, a bit more than if you were working as a hospital-based employee. But that comes with because you're seeing an increased volume, which I also think is the con here. I think I was scheduled on average about 18 patients a day, maybe 2 no-shows a day. So it's very busy. You do feel a bit more isolated working in private practice. Many times I was the only physician in the whole clinic. And you don't get to see many colleagues. There's less support staff, especially with growing labor costs. In the past few years, we did see, it was difficult to keep staff. And as a result, it was, a lot of times a lack of support staff. There's less built-in time for in-basket sleep study reads, desktop medicine in general. And that just kind of ties in with the volume and compensation. The more patients you see, the more, sleep studies you read equals, profit for the clinic. There was also a lot of prior auths, and that was a bit of a nightmare, especially with less support staff. So that would definitely did drain a lot of my time. And then, with increasing labor costs and overhead, something I've touched on multiple times kind of throughout this presentation already. Then we kind of shift over to more of a hospital organizational based practice. There is, this term you hear called HMO, or health maintenance organization, versus a hospital based practice. HMO, basically, like Kaiser, it's basically its own insurance, right? You work for the insurance. It has its own network of providers, physicians, hospitals, and many times the members pay a subscription, monthly subscription, or a yearly annual fee to gain access to this network. Versus kind of a hospital-based practice, it does take, commercial insurances. And you serve as basically an employee. You're compensated mostly by a salary with potential, RVU, additional compensation as bonus. And there are so many different sizes of hospital systems, right? It could be just one hospital in, somewhere in Montana, or it could be a large multi-network hospital system that you could work with. So this really varies. And sometimes these can be owned, again, by private equity or insurance companies. So I know that one of our hospitals in the Washington area was just bought out by Optum Health. So definitely there's going to be changes to practice styles as well as standards, I think, in the next few years. So some pros and cons, I would say, is pro stability. You work for a big organization. Many times you don't have to be, you can be less of a bean counter and kind of enjoy the perks of working at a large organization. There are multidisciplinary colleagues you get to, bounce ideas off of. There's a large referral base, so you don't have to worry about getting your own patient base. I would say that the work-life balance is better. Benefits, such as, 401k match, HSA, et cetera, I would say in general are pretty good. I think Kaiser also offers a pension. So, benefits typically are better than private practice. And some are PSLF eligible if you have student loans. And there are less prior auths. I would say working for Kaiser, I haven't had any prior auths during my 1 year here. So that's been wonderful. Con, it's an onion, okay? What does that mean? There's many layers to this organization. Many times it's kind of a top-down type of practice. And, sometimes there's, you feel like you're behind curtains. You don't know what's really going on above you. And sometimes you're told what to do, right? Because at the end of the day, you work for this organization. The top people decide certain, practices or financial decisions. So it is very different versus in private practice. I think if you want to enact a change, it's a lot easier because it's a lot smaller of an organization. And then kind of this culture, I wouldn't say that it's purely a con. It's something you have to kind of learn, through your time. There's certainly, more of a corporate culture to working in a larger organization. And there are certain ways people speak, certain terms that you have to learn and understand what it means, because some things are not as straightforward. So it's a learning curve. And then, kind of to rehash that, there is more, I would say, limited autonomy when you work for a larger organization. So the current organization I work for, Washington Permanente Medical Group, it's an HMO system. It has about 700,000 members. During my day-to-day, there's built-in sleep study interpretation time every day, which is great. There's also admin time for program development. There is some teaching that I can do. We do have our family medicine residents that come through occasionally. Now, one thing to note is that we actually don't have a sleep lab. It actually closed back in 2021 before I started my job. And I took this into really heavy consideration when I signed for the position, because I'm like, well, you have 700,000 members and you don't have a sleep lab. But unfortunately, It's just, it wasn't financially feasible. And it was, kind of going back to all the cuts that were occurring. And then, so most of our patients actually do home testing, okay, which has worked pretty well. And then we refer out for in-lab testing to all the other hospital systems. And, one of the reasons we don't have a sleep lab is that if you take a look geographically at, the area of patients that we cover, it's really big. Okay. So this is King County. This is where I'm at. This is kind of Seattle and Bellevue and Kirkland all here. And then this is kind of Tacoma and Pierce County. But we only have in-person providers and physicians kind of in this small area. But we have patients located throughout. And actually a lot of them are located in, Pierce, Thurston, Lewis County. There's also some patients in Kitsap, which is honestly, they have to take like 2 ferries before they can get to us. So it's not, geographically we're limited. And if we were to run maybe one sleep lab here, then what about patients from all over? It just, a lot of it was, they kind of did the cost analysis, and it actually works out a lot better when we refer out for our in-lab sleep studies to different sleep labs throughout the community and the state. And the other thing to touch upon is that, access to care, that's a big part of my job right now, is to really determine ways to help our patients who are, say, in Spokane, to gain access to, the care they need in sleep medicine. And therefore, home testing as kind of a first line is very helpful, especially, since you can mail a watch PAT study over. So kind of touching upon medical directorship, I'm very new to this role, just started 2 to 3 months ago. And it has been a very steep learning process. It's more like drinking water from a fire hose. It's, every day there's something new I'm learning. So kind of a bit about the role. The biggest thing is program development. And in the next kind of 6 months, the plan is to kind of develop this fast track system where it's kind of expedited testing for patients before they can see, even before they even have to see a provider or physician. We're able to send them a home testing kit for them to test. And if, they test, high pre-test probability and everything, then we would actually treat them with CPAP. And they did a test run in Tacoma, just kind of in a smaller geographic area, and it's actually worked very well. Now, obviously, there are downsides to it as well, but that's kind of my job to kind of help troubleshoot that. We are also kind of developing our Inspire program. Currently, we do refer out for a lot of our Inspire implantations to the University of Washington or Swedish, but that is something we're hoping to start end of this year, working with the ENT department, as well as Kaiser Colorado, to kind of both develop this program concurrently. The other important thing, part of this role is to improve access for our patients. Now, if you work for Kaiser or a lot of HMO systems, you will hear this term, access, access, access. And what that means is basically from the time of referral to the time they're seen by a provider or physician, what is that time? And our goal is for 80% of our referrals, we're hoping to see them within 2 weeks. And that is, a very ambitious goal. Most sleep medicine, usually the referrals are, months out before they actually see someone. So, but this is, that's one of our goals for membership. Just because how the HMO system works is that, they pay this subscription, and we found that if we improve access, then it keeps them happy. It keeps them, in the HMO system. And also, a lot of my job does entail working with the other medical directors in the Colorado, Southern California, and Northern California branches to, come up with program development that is per KP national standards. So, Southern California has definitely a very different system than our system. They actually have trialed using primary care to order most of their sleep studies to kind of achieve this access goal. However, they had to quickly dial that back as they've realized that they're way over testing a lot of their patients. So kind of really brainstorming with the other medical directors in, improving care to our patients. Now, many times if there is a sleep lab, the medical directorship role, a big part of it is to making sure that this lab is accredited. In my case, I don't have that responsibility yet, though I think there are plans potentially in the future to kind of restart this sleep lab. So other gigs that kind of have popped up along the way for me, one of them is medical writing. I'm actually one of the medical review panel for sleepfoundation.org. And this is really fun for me. This is something that I think prevents burnout from just seeing the clinical side to things. I get to write something, I get to edit. And some fun articles I've contributed towards, side effects of sleep medicine. What is the Scandinavian sleep method? Best foods you can eat for sleep. So this is a lot of fun. I usually do 2 to 3 articles a month. I also do some consulting on the side, though I haven't for some time now, just because how busy this, the Kaiser position has kept me. But I've worked with some pharmaceutical companies and international PAP device makers. They wanted to consult in regards to, how, for example, Jazz Pharmaceuticals, they wanted to learn about, how they can best reach a good audience with their, medication or et cetera. And these are more one-time, two-time gigs. I don't plan on doing consulting as, my formal gig. I found from just these 1 or 2 experiences, consulting probably isn't for me. But both these opportunities, it just kind of found me on LinkedIn. So just kind of to add to this, improve your LinkedIn profile, put a nice picture, keep it clean, and look at your messages. You never know what's going to come through. And I would say that these are things that, can enrich your career along the way. So other career paths and practice settings, obviously a big one, academic sleep medicine. So these are probably your mentors right now, your colleagues, and they can much more give you a better picture than I can. But academic sleep medicine is a big one, plus or minus research, plus or minus teaching in the med ed realm. There's also something called industry. And at first that was a bit nebulous to me, or, unclear in terms of what that means. But, the more I kind of look into it, it's basically, you work for pharmaceutical companies. Typically, they're looking for someone more mid to late career from an academic setting. Who have, contributed a lot to probably, a lot to literature, who are at the top of their fields with particular expertise in certain areas. And, it's a very rewarding field from my understanding. I have had colleagues early career with limited research experience get into industry with good networking. So it is still a possibility for early career physicians. And then, consulting for tech and startup companies, especially with, the changing landscape of sleep medicine. A lot of these startup companies are cropping up left and right. They're looking for, physicians to sit on their advisory board. Again, a lot of times they're looking for specific expertise that you can provide, and they really look at that CV and your experience in whether it's consulting or research. Then you can create your own practice, right? A lot of people nowadays, they actually create a virtual practice, which is very, it's conducive in sleep. So, a low overhead, you can decide to do that coming out of even fellowship. Of course, you can always establish the brick and mortar sleep center with a sleep lab. But, it does take business acumen, a passion for it, and it's a 24/7 job, opening up your own practice. So, but, it can be very rewarding. You are your own boss. And, this is something that, who knows, right? Maybe I can do, maybe, I can, you can kind of consider asking your colleagues, your graduating cohort, if this is something they want to do, a team up, do this together. So I think we need more physicians, setting up shop. So I'm always a proponent for that. There's also utilization review. Now you may ask, what is that? That's actually working for the insurance side of things. Some people transition into that later in their career once they're a bit maybe burnt out from clinical practice, but you work with insurance, you're probably that prior auth, the peer-to-peer person. And I encourage people to go, sleep doctors, to go into this, because there were so many times that, I try to do a peer-to-peer and I'm talking to someone and they have never ordered a sleep study in their life. And I'm like, why am I talking to you about this? Why am I trying to have you approve this sleep study for the patient? So so that's definitely a career path, you can consider down the road. Now, there's also a lot of people that go into, a mix of their primary specialty with a mix of sleep. So you don't have to practice 100% sleep. And then lastly, there's so many possibilities, right? So I wouldn't really limit it to any of this. Really explore, kind of find out what your passions are, what you want out of life, what you want out of your career, what your personality is. I really think the possibilities are endless here. One thing to look at when you kind of decide on a position, I think, or kind of a practice setting, is support. Support is very important. One thing that I really look at is, does the program have a strong CBTI program? Does it have a board certified, sleep psychologist? And that is very invaluable. So also kind of goes hand in hand. How is their mental health support? Is their mental health program good? Because a lot of, patients with insomnia, a lot of times it's anxiety or depression driven, right? And that was one thing you kind of lack a bit in private practice. You don't have, a lot of these practices don't have that connection with, a psychiatrist or a mental health department. So kind of a lot of these patients, it's kind of left, you're managing some of the depression and anxiety as well as their insomnia, as well as their, other sleep disorders. So it can get a bit overwhelming when you don't have that good support system. CPAP troubleshooting. So this is something Kaiser does very, very well. We have a department called OSAS. It's run by a group of respiratory therapists. They are wonderful. They make my job so much easier. They help with, PAP desensitization. They do mask fittings. They actually change most of the pressure settings. Okay. And then obviously I'd have to review and sign off, but especially for APAP settings, they're really, really good. And I would say that's why, our success rate for CPAP is very high. It's because we have such a great team that are able to really take the time out to help our patients, with their CPAP troubleshooting. And I think that's also part of the reason why Inspire was not introduced into our practice sooner. It's just because everyone's using CPAP and they're using it so well. But of course, Inspire is needed, whether we like it or not. So that is something that, we're working on as well. MAs and nurses, that goes without saying. PAs and NPs, every practice I've interviewed at, have, PAs and NPs also, seeing sleep disorders. And that's really invaluable to, make a really, complete, I would say, practice. Sleep techs. This wouldn't really apply to currently my position, but I do remember U of M, the sleep techs were very strong, which made our jobs a lot easier, kind of asking that question, like how strong, how experienced are your sleep techs? How long have they been doing this, etc. And then lastly, the different multi-specialties and their accessibility. So ENT, sleep dentistry, other specialties, these are all things to consider when kind of deciding on a practice or kind of, what kind of path you want to go down for your career. So kind of to summarize some of my pearls that I've learned. So the first thing really is to determine your kind of priorities and interests before you decide on, kind of a path, right? Do you want to do academic medicine? Do you want to work in the community? Do you want to work in a large, or do you want to work in a smaller program? What's your personality? What's your goal in life? Are you kind of a, go-getter? Are you someone who wants to make something and, invent something? Or do you want, enjoy the stability of certain things, right? Do you want to practice in a multi-specialty group, or do you want to practice in a group that's predominantly neurology or pulmonology? These are all important questions to kind of ask yourself throughout your career, really. And then the other thing is sleep medicine is a small community. Okay, it's even more so than a lot of the other specialties. So, your reputation is probably the most important thing you have. Okay, and it's really important that you maintain a good, reputation, a good kind of personality when you're at work. And networking is really important. A lot of times I would just cold email or call clinics, and I have gotten interviews that way. Utilize the large U of M alumni network, and your cohort, right? Like the beauty of a large fellowship program is that you have so many people in this group to bounce ideas off of, not even just during fellowship, but even after you graduate. I still keep in touch with, my graduating class. We have a very active group chat. So that's really important. And I do know that two of my colleagues, they found jobs for each other based on just talking to each other. So really kind of maintaining that network and going to maybe even sleep meetings. The AESM meeting is coming up, the sleep meeting in Houston. So don't limit yourself, and just kind of really, make sure you maintain a good network. The other thing is to kind of keep things in perspective. Nothing is set in stone. I would say more than 50% of practicing physicians change their position within the first 2 years after graduating fellowship. So their first job, most people actually change. So if you don't like a place, if you feel like it's not, it's not making you happy, then, consider changing, right? And nothing is set in stone, right? So don't be afraid to kind of make that jump. There's also no perfect job either. Okay, so every job comes with its pluses and minuses. There's no kind of perfection out there, and it's just kind of what you feel like is your priority, what you feel like you can compromise on, and do you feel professionally satisfied? I think those are some important questions. And then my favorite life motto is really, life is not a box, right? There's no set practice setting and way to practice these days, I feel like. There's, I would say maybe even like 20, 30 years ago, people work at a certain job, they work there for 20, 30, 40 years, they get a pension, and life is great. But nowadays, everything is so, it's fluctuating, right? Like, especially tech workers, they change a position every 2 to 3 years. And I'm not encouraging you to do that, but what I am encouraging is, for people to kind of explore a bit, right? Don't just limit yourself to a certain idea and then kind of just keep going down that route, even if you're not happy in it. For example, there were a lot of job postings, I think, that the posting said they were only looking for a pulmonologist who can do some sleep medicine. But, I still just cold called them. I still, sent in my CV, and I actually ended up, getting offers from a few of them because I marketed myself in a certain way. I kind of did my research, what I think they will need, and really tried to market myself in a way that I think, that we can both benefit. So don't just, take things for what you read on maybe even a job posting. Kind of explore that a bit if this is an area that you're looking to be in. Lastly, I like to kind of just talk a bit about kind of primary care going into sleep medicine. My previous slide, I noted that, there is a lack of sleep specialists. But quite honestly, our system is not set up very well for a lot of primary care, internal medicine or family medicine to go into sleep medicine. I do have colleagues, with primary care background, they graduate fellowship, but it's hard to find a position, right? And it's remiss that we're not utilizing these physicians, because a lot of these jobs, like I said, they're looking for someone, with a neurology or pulmonology background. Now, this is changing, but at the same time, you have these graduates who can't find a position in sleep medicine, and then they end up going back to their primary specialty. And then it's like, well, will they ever kind of go back into sleep medicine? Unknown. But, this is just kind of a comment and, something that I do think will change in the next few years. But, don't be discouraged if you are coming from primary care and, there are limited positions, explore a bit and just keep trying. So that's kind of my presentation. Any questions, comments? Love to hear other people's, thoughts.
Lulu, that was fantastic. Thank you so much for that overview of different practice settings and also sharing your journey. I was wondering if you could speak more about making a change or pivoting even after a couple of years. I know when people are looking for what's often the first job, maybe the second job, that doesn't include training. It's a little nerve-wracking, and there's a hope that maybe this will be the forever job, but maybe it's not. So what are some things that you would recommend to our fellows or anyone at a similar career stage, such as what you've described, in terms of kind of knowing when to take that leap and switch jobs even after a couple of years?
Yeah, I think well, for me, it was more of a, my husband graduated from Arizona. We wanted to move from Arizona because there was a lack of water, et cetera. We were missing trees. So, we loved the state of Washington. But, outside of that, I would say that there were certain times, I think, in my last role that I just felt like it was stagnant. Like wasn't progressing, I think. It was great that I was seeing these number of patients, but I just felt like professionally, I wanted to still learn, and I still, wanted to take on roles that maybe this position would not offer to me. So that was kind of the other reason. I changed roles. Also burnout. That's a big one too. If you feel like, if you're going to work and you just feel like, hey, this is not fun. This is like, you're dreading every day. I mean, everyone's going to have bad days at work, right? Like everyone's going to a few times a week, you're just kind of like, oh, okay, it's Friday. But yeah, if it starts kind of like taking a toll on you mentally, I think that's also another sign that it's time to make that change. And the thing is, as a physician, you're somewhat always in need. Okay. So I don't think there should be really a significant fear that if I quit this position, am I going to ruin my career? There's so many different ways you can pivot yourself, that I don't think that, that should be a huge concern. Now, if you have to be geographically tied to an area and there are limited sleep medicine roles, which in many areas there are, then yeah. But if you have kind of the flexibility of moving around, I think that then don't fear making that change.
Great, thank you. I don't see any questions in the chat. I don't know if anyone would like to unmute and ask a question. Tim, go ahead.
Hi, Lulu. Thanks for a wonderful and very engaging talk. And it's great to see you again. I'd be interested in hearing a little bit more about your experience with referrals for in-lab polysomnograms. How has that worked logistically? Have you encountered any barriers so far as timeliness of access to reports, quality of interpretations, things like that?
Yeah, great question. So that's something I would say is not consistent. There are definitely labs that do a lot better job in interpretation as well as timeliness. Unfortunately, some of our more peripheral patients and the labs may not be as timely, and that is something we're working on. It's just the access is poor. It's many times like a 2-month wait in order to get a sleep study. And we're working on it, but ultimately it is limited by what resources we have and, you know, how many sleep doctors they have to read the studies, how many sleep beds they have. But that's something that, you know, it's kind of a work in progress right now. I would say that, you know, a big downside of not having a sleep lab is, you know, you see a patient, you want to read their sleep studies, and sometimes, you know, you just can't, right? So you do have to know who are the better sleep study interpreters in the community to refer to when you have certain patients, but you kind of get an idea of that, I think, with time too. So that's the other challenge.
Thanks. Ron, did you have a question?
No, yeah, I guess if we have time. Well, first I wanted to congratulate you. That was a great synthesis of knowledge you only get one way, and that's not from reading the textbook. So thank you. I was interested in what you said about the difference between labs in academics and outside that it's hard for the lab to generate not a profit or margin. I mean, here we call it a margin, but maybe in practice you call it a profit. But um, is that solely, do you think, because if you're outside a hospital setting, then you have a global billing charge, which in some is less than the separate technical and professional fees that a hospital setting would do? Is that the big difference?
Yeah, I think that's definitely part of it. I think from my understanding, you know, if you're at an academic institute or, you know, tied to a hospital and your sleep lab is done, or your sleep study is done in this hospital setting, insurance actually reimburses the, you know, the hospital fee portion of that sleep study, which is actually a large part of it. From my understanding, I think in-lab sleep studies at a clinic setting is probably, I think you get reimbursed maybe 800 at most, 800 to 900 these days. So it's not a lot, especially with, you know, the overhead to run these sleep labs. And that is a big reason I think a lot of these sleep labs closed, you know, a decade ago when that reimbursement shift. Now I'm not, you know, familiar with the margin of the U of M sleep lab, but, you know, the other benefit is that it's a very large organization, right? It's a large healthcare system. So there's a lot of yeah, room in terms of, you know, say the GI departments, you know, very profitable, or there's a high margin there. It can make up for maybe, you know, a month or two of the sleep lab margin being lower. So there's kind of that flexibility there. Whereas if you're just solo practice or private practice, there's really not that flexibility. You have to really consider, you know, month to month, are you meeting your financial goals?
Thank you. Thank you for the presentation.
Thanks again, Lulu. I don't see any other hands up. You did get some kudos in the chat. So thank you again for a wonderful talk. And it was fabulous to see you again. And congrats on all of your success. You're doing so well.
Thank you so much for having me. Anytime.
We'll take you up on that.
Okay, take care.
Thanks. You too.
Bye.
Thank you.